I'm excited to share with you guys the X-ray fundamentals and positioning within the technique of EPIC to kind of give a frame of reference of why we do what we do in the analysis and why we view things in a certain way. I know there's some small nuances between the different techniques, and just wanted to share how we do it in EPIC. This will be the first video of many to kind of walk you guys through each of the steps of how we analyze currently in EPIC. My name is Dr. James Beadle, and happy to answer any questions I can within the realms of EPIC. I've been teaching EPIC for several years, even when I was a student in school at Life West. And so I graduated in 2012 and have been a part of EPIC since 2013. I worked with Dr. Stan Pierce and Kelsey Wigington, and have been a board member up until this year. And so wanted to just let you guys know who I am, what I'm doing, and why I'm doing it. I'm also the creator of Sonus, and I'll be going over that on a different video to help you guys understand how the X-ray analysis ties into Sonus and how we use Sonus to help us adjust people and to track our results. So first off, we've got the right-hand Cartesian system. You got the XYZ coordinates as far as vectors are concerned, but you also have the different plane lines. When we reference the X-ray views themselves, it's based on the planes, not necessarily the vectors, because that can get a little confusing. We did have a switch in terminology when we went from advanced orthogonal to EPIC. We wanted to clarify some of the terminology just because the phraseology would switch with different anatomy parts being referenced first, and then it was an X-ray view, but then another one, it was an X-ray view, and then it was the anatomy, and it was just confusing. So very simple. We always start with the X-ray view first, right here. You can see that with the sagittal, frontal, horizontal. The next acronym is a structure, and if it ends at that point, then it is just a line or a rotation. If it has all three, then you're looking at some sort of comparison or an angle. So when you say FC line, well, that's going to be your frontal cranium line. Your FA is going to be your frontal atlas line. And this is important because you'll see you have an FA, but you also have an HA. HA is in the horizontal plane line. So currently it's very, very important when we're looking at the 2D. When we go to 3D, it will shift a little bit and actually get way more complicated. But just wanted to let you guys know this is the terminology of how we actually communicate in EPIC. I've put a Word document on the folder shared with everyone so that you actually have it all written out and explained there. So first off, we're going to start off with the sagittal view. Again, you got four views that we use in EPIC. You got the sagittal, the horizontal, frontal, and the axial, and have the axis reference points there in case you are wanting to know what they are. So first, the sagittal. Why do we take it? Well, first, we need to look at pathologies, fractures, and degeneration to also obtain the measurements from which to take the frontal and axial films, and to cross-reference with the other films in locating the atlas transverse process. This is some of the anatomy that we're looking at, and this is how we actually position them with the X-ray system. So first off, we actually set the X-ray tube to 0, and the patient is placed perpendicular or 90 degrees to the bucky. The shoulder touches the bucky, and to eliminate head rotation, we actually use the chair, and we're looking at the lateral canthus of the patient's eyes, and we leave the patient's head tilts. So once we see that there's some head tilt, then we would actually tilt the tube and the bucky to match the patient's head tilt, not to actually move the patient's head tilt. So I know some techniques will do that. As far as the central ray is concerned, you want the hard pellet level, as with all the other techniques and other X-rays. You have the horizontal line, and the crosshair is a line at the level C1. You can see that right here. So this is that horizontal line. and the vertical line is at the EAM. And we don't collimate to allow the facial features to be there. As far as the quality or how to know if it's actually done correctly, and this is still important for CBCT, is we want to make sure the superior and inferior rami of the mandible are superimposed on the film, and we want less than 6 millimeters of rotation or lateral flexion. The facial features are visualized, and the hard palate is level and clear. And we also measure the rami of the mandible or the eye orbits. Typically, it's just the mandible. Very rarely do we actually use the eye orbits. And C1, C7 are visualized. This gets kind of fun to talk about as far as CBCT because we have to talk about what is a 0 point for the skull and what is a 0 point for the atlas and what is a 0 point for the spine. And each one of those are very different in dynamic comparison to each other. This is how we look at the posterior double eye orbits. It'll be like a fuzzy hard palate. Again, this doesn't really apply as much with the CBCT. As far as the analysis goes, we're looking at three main things, but there's other considerations that we look at. And when I do the full-blown analysis, I'll show you what we look at. But you have the sagittal atlas line, which is the SA line. In advanced orthogonal, you'll see these asterisks. That's what it was before, so it was the ASP. So it was the atlas sagittal plane before. How we measure that is we put down a calculations box for the view, and then we use the tool called the Epic Sagittal Atlas Line, the SA box. The first dot goes in the corner of the posterior lateral mass and the inferior posterior arch of C1. You can see the red dot right there. And then we go a quarter inch behind that, and it will automatically scribe this line, and it will give you a numerical value for the degrees. Once you have that, if there are two arches, just so you're aware, then we'll go to another slide and show what does that mean. But sometimes you have a double arch sign, and you would actually use the top one, or the one that's higher. If the angle is over 20 degrees or above an S3, you want to take the frontal view at an S2 at 10. I'll describe why we do that. All right, then you press or click the line and press that question mark, and you'll enter in a facial feature code. This will collaborate with what facial feature you're going through when you're trying to take that frontal view. So for this one, it was a S2 at negative 15 because you're coming down at 15 degrees. Okay. As far as the lines are concerned, you have S0, S1, 2, 3, 4, 5. I believe it's a little different in other techniques. I'm not quite certain. I do know that we don't do eye numbers as you go inferior. So kind of confused on that one. I don't know why it changed from the other techniques, but this is how we say it. There's another way to view those S lines. We do say like this is a -1, -2 when it gets down below the mouth. As far as that posterior arch sign, there's a few reasons why this can happen. You can have a actual tilted atlas, or an aberrant posterior arch, or condyles, or C2 body, which would cause it to look like a double arch. So we're going to zoom in on that picture right there. You can see how you have two posterior arches going on. So the patient's not rotated, the patient's not tilted, but the actual structures are rotated or tilted. And when that happens, you take the higher S line to actually get a better view of the film from the front. As far as the SAX, or the sagittal axial line, it used to be termed the axial angle. We use that for the axial x-ray. I'll explain why we do that later. So we place down, or use this tool right here, which is the Epic Sagittal Axis line. We place two different dots. The first dot goes to the posterior inferior portion of C2 dens. The next one is the posterior inferior body of C2, and it scribes a orthogonal line like that. You need to know those three things, and you're going to place the facial feature code, which this one will be at 0. is at a 0 at negative 1.59 degrees. Okay, so once that's completed, just to kind of show what we're trying to do these for, the first one, the SA line, is going to show us the frontal. So you have the X-ray tube coming down through here, takes that X-ray, and this is what you get from the front. And then from the axial, you're looking at from this direction to get that axial circle down here. Okay. All right, now we're going to move on to the frontal. Why do we take it? We need it to assess the biomechanics of the vertebral misalignments for proper table placement, and to measure the exact line of drive required to realign the cervical spine, to cross-reference with other views to locate the atlas transverse process. The big thing is that this view right here is going to give us the Z of our vector of how to actually fix someone. So it's very, very crucial on this one. With CBCT, what's great is that we're able to take the skull and the atlas and the lower neck and view it at different plane lines, which is going to be way better than what we're doing currently. This is some of the anatomy that we look for. As far as the position is concerned, you set the X-ray tube to the SA. The bucky is tilted to match the patient's posture. The patient is back in occiput. Touch the bucky. Remove the head rotation, looking at the lateral canthus. I'm leaving this in because I need to kind of reference back to what is 0 when we're looking at these different structures. And it's important to know what we're actually looking at when we're adjusting the patient. So as far as head rotation, it's lateral canthus. You want to leave the patient's neutral head tilt. So if there is a head tilt, you would leave it in there and place the head clamps over the mastoids. As far as if it was done correctly, you have less than 2 millimeters of head rotation. And again, we're looking at the lateral edge of the eye orbit to the outside edge of the skull and comparing that right and left. I'm gonna zoom into this next one just to show you, but I'll read this off first. The zygomatic bone will intersect with the mastoids equally, and then the nasal cavity compare with the lateral aspects of the atlas, lateral masses. We don't use that as much, but it is there. We don't like that one as much because you're losing a skull-to-skull reference point at that point. As far as the visualization, you need to be able to see the condylar surface and the 4 parts of the atlas that we look at when we measure the atlas. Okay, so the first one, we're going to describe the eye orbits first. From there, you got the sutures that come down as the frontal zygomatic suture, and it creates an X right here. From that X, you measure that out to the edge of the skull, and that should be equidistant. Where it's getting complicated with CBCT is that we're noticing that some people's skulls are actually bent. And so when you're looking from the top down, there's no rotation as far as the eye orbits are concerned. But then when you're looking from the front, the skull is actually protruding a little bit. And so you'd actually say that, quote unquote, the patient is rotated, but in actuality, they're not. So it's creating some discussion of how do we actually, again, determine what is 0. But as far as right now, as far as the 2D, this is what we're looking at. The next one is going with the mastoid processes in comparison to the zygomatic arch. So the blue one is the zygomatic arch. You can see how it matches up with the 2 right there. The last one is going to be your nasal bone. So we're going to describe the 2 parts of the nasal bone. It's in green, a little hard to see, but we're comparing that to that lateral mass. All right, now we're going to go ahead and go to the next one, which is the axial. Lots to read, but basically we're just saying that if there's a 7 degrees or more difference between the SA and the SAX on the sagittal X-ray, then to take out the distortion, we need to take this axial view. And I'll show a picture of why that's important. But the big thing is that the condylar and axial circles, when they are compared with each other, it drastically changes that Z calculation that we use to adjust someone. So this one needs to be, perfectly along that plane line. All right. Completed analysis, so you come from here with the sagittal, and that lets you know how to take that axial view. Why we take it? Well, we've got to rule out the fractures and genetic anomalies and pathologies. But the main one is to measure the curvature of the C2 superior surface, and that, again, that's used to calculate the z coordinate of the adjustment. To also cross-reference with other films for locating the C2 spinous process and the width of C7 and C6 vertebra. As far as the anatomy, it's pretty simple. That's what we're looking at. And patient positioning, again, it's right here. So we're saying the tube angle to the SAX. The patient position is with their back touching the bucky. Remove the head rotation using the chair, but you are going to leave the head tilt. And again, we're using the head clamps or the mastoids, and the mouth is typically open at this one. As far as if it's done correctly, you should be able to visualize the axial superior facet surface and less than 2 millimeters of rotation. You can leave rotation, but then you lose your cross reference ability. So for the as best as you can, you want to take out the rotation on this one. All right. To show why we take this one's taken actually directly along the plane line of the C2 surface. And when you compare that, when you add 10 degrees, or like let's say your frontal x-ray was done with a little bit higher tube tilt, then the facets start to round. And if they start to round too much, it drastically changes that value that we're getting. So we're just showing you here how flat they are here in comparison to getting rounded and more rounded. And so it's just crucial for us that when we're analyzing this x-ray, we want to be straight across this way, or else it would change our z vector. And again, just showing the necessity of this, how clear it can be. Again, with CBCT, not really an issue. But here you go. Here's the actually old way of how we would use these templates to know what the diameter of the not the diameter. Sorry. Yeah, the diameter of the actual circle being from a frontal perspective versus an axial, and that is a big difference between the two. Here's a case study that we show people, but again, the big difference is that because there's such a drastic degree difference here, we have to look at this on a different view or plane line, and when we do that, it actually changes the z vector for at least 10 degrees. So again, it's what's neat about the CBCT is that we're going to be able to look at the cervical spine on a certain plane level, the atlas on a different plane level, and then the skull on a different plane level, and combine all those values to instead of having to just look at one view or even just two views. This one is just talking about using an S2 at 10 rule. Let me show you this one. Essentially, with the SA, if it's too high, then you start getting a lot of distortion going on down here versus over here. So we would take an S2 at 10 instead of the actual one it was done at. That's okay. We don't have to go into that. As far as the horizontal is concerned, why do we take it? Well, we want to measure the rotational coordinate. That is the exact line of drive required to realign the cervical spine, and to cross-reference with the other films for locating the atlas transverse process. And when it says cervical spine, it's really actually your C1 rotation, right? If your C1 is rotated in comparison to the skull, that directly changes everything as far as the alignment is concerned. Excuse me. This is the anatomy that we're looking at. You just pause it if you want to go through those. As far as the position is concerned, the X-ray tube is set at 50 degrees, and the bucky is tilted to 30 degrees. This will be very interesting. Again, with CBCT, we're trying to figure out what's the best way to view this. We're going straight perpendicular from the atlas, from the condyles, from the skull. What are we really trying to look at? So we haven't really defined that one yet. If the patient's chin is on the bucky, central ray goes through the crown of the head. We're going to remove the head rotation and also the head tilt. Again, we're using the chair to take out the rotation. And as far as the head tilt, we leave the head tilt in there, but we tilt them at the torso to get the head straight up. And then we obviously use the head clamps for the parietal bones. As far as the quality, or if it was done correctly, the whole skull needs to be visualized. The atlas will be on the back near the internal occipital protuberance in the posterior parietal region of the skull. Then you have the frontal groove and the IOP, or the internal occipital protuberance, are in the center of the skull and the film. There's less than 2 millimeters difference between the lateral edge of the zygomatic bone to the edge of the skull, which is this one right here, and between the angle of the mandible to the edge of the film. So I use this one primarily with the CBCT. And the frontal groove is to the edge of the skull. Okay. With that, I'll go ahead and switch gears and go through the analysis and help you know why we do what we do with our analysis.